highlight some points how we to approach to the acute febrile illness and কিছুদিন আগে একটা কালের কণ্ঠতে এরকম একটা হেডলাইন ছিল, ঘরে ঘরে যার 25% ডেঙ্গু ফিভার। এবং আমরা জানি এখন আমরা একটা গ্রেট আউটব্রেক অফ ডেঙ্গির মধ্যে দিয়ে যাচ্ছি। প্রতিদিনে প্রায় 2 থেকে 2,500 রোগী সারা বাংলাদেশে ভর্তি হয়। তো সেই হিসেবে দেখা যাচ্ছে আসলে হিউম্যানিটির 3টা এনিমি বলা হয়, একটা হলো ফিভার, ফ্যামিন অ্যান্ড ওয়ার। সুতরাং আমাদের এখন সবচেয়ে মোস্ট টেরিবল থিং হলো ফিভার, এবং দ্যাট ইজ দি acute febrile illness also as well as the dengue fever. It is said by William Osler, the great physician of 19th century. Acute febrile illness সম্বন্ধে বলা হয়, it is a most common cause of hospital admission in Bangladesh. This illness contribute considerable morbidity and death among children also as well as in the adult. Diagnosis remains challenging as it is a common presentation of many infectious disease. Even up to 80% of febrile illness cases may remain undiagnosed. So first of all, what is how we define fever? It is the morning temperature if it is more than 98.9 degree Fahrenheit, or evening temperature, it is 99 degree Fahrenheit, we call it fever. However, in practice, in general, threshold of temperature is 100 degree Fahrenheit. There may be diurnal variation, and the commonest site we measure is the oral is the best, axillary is less than the oral temperature recording. But other sites also, but it is very difficult to approach the lower esophageal temperature, rectal temperature, and the tympanic membrane thermometer may be used to record the temperature. In case of children, oral temperature recording is very difficult, so surface temperature is easy for the children, also in the unconscious patient. If we look the pathogenesis of fever in short, it is the infection or microbial toxin or mediator of inflammation, whatever may be. There is a activation of monocyte and macrophage and the endothelial cell and other cell also, which liberate the pyrogenic cytokines, that is interleukins, especially the interleukin 1 and 6, and also TNF factor and interferon. All these chemical cytokines, there is a enter into the hypothalamic endothelium, they liberate prostaglandin E2, which activate the cyclic MP. Ultimately, they elevate the thermoregulatory set point. That result in heat conservation and heat production, leading to fever. Even the microbial toxin directly stimulate the hypothalamic endothelium. This is in a short how the fever occur. But in hyperpyrexia, this set point is normal. That is the basic difference between the hyperpyrexia and the normal fever. And there are some stimulator and inhibitor of the fever. If we see the inhibitor, those reduce the fever. One is the corticosteroid. Those are especially acting on the immunological disorder. They release the prevention of release of pyrogenic cytokines, steroid. Second, prostaglandin E2 relief inhibited by the antipyretics. That is how we are using practically NSAID and paracetamol. And datrolin, which is used in hyperpyrexic condition, they inhibit heat production and heat conservation. So this is the 3 agents where they acting in different ways to reduce the fever. There are some studies done in Chidong Medical College and published BMC Infectious Disease 2016 and onwards. One of the studies is the prospective study of importance of enteric fever as a cause of non-malarial febrile illness in patient admitted to Chidong Medical College Hospital. This is done by the Moruguru and Chidong Medical College jointly. They found that about 70% of the enteric fever and 16% about lower respiratory infection, non-specific febrile illness about 16%, CNS infection about 12.3%, urinary sepsis 7.7%, upper respiratory infection about 7%, diarrhea or GIT infection about 7%. So this is the result of acute non-malarial febrile illness study group. Another study done in Chittagong Medical College, rickettsial illness as the important cause of febrile illness in Chittagong. And this prospective cohort of hospitalized febrile patients shows about out of 416, 96 were positive for rickettsial illness and was attributed to rickettsial fever. So this is another evidence of rickettsial illness in Bangladesh, especially Chittagong. And there was another study done by ICDDRB, also published in BMC Infectious Disease, prevalence and clinical presentation of rickettsia, Coxiella, Leptospira, Bartonella, and Chikungunya virus among hospital-based febrile patients from December 2008 to November 2000 in Bangladesh. And in this study, it was found that about 37% were rickettsia, and also 10 patients were identified Coxiella, 2 patients from Leptospira, and 1 patient for Bartonella. So there is also a small group of patients, Coxiella infection and the Bartonella infection in our country, though they are rarely diagnosed due to lack of facility in our country. Now, our today's main topic is the acute febrile illness. We grossly divide this acute febrile illness into 2 groups. One is acute localized infection, that is, there is evidence of sign symptom of a specific system or organ infection. As for example, we can say respiratory infection, urinary infection, or GI infection, or CNS infection. But another group, acute undifferentiated febrile illness, because they have no localized sign symptom initial phase of the disease, but later on they may develop sign symptoms when the fever persists 5 to 7 days. That is why initially they are differentiated as undifferentiated febrile illness or AUFI. And there are 2 groups. Basically, we differentiate between the malaria group and non-malaria group by doing the RDT test, which is easily available and very specific and sensitive, more than 90%. And among the non-malarial group, there is a viral group, especially this time the outbreak is the dengue. Previously, there is chikungunya. Zika is still not recorded in Bangladesh. Only 1 case recorded in Seram, and Japanese encephalitis, especially the under 15 children. Also influenza and COVID and other viral infection, also if they are not initially presented in with sign symptoms, major sign symptoms. Bacteremia, especially the enteric fever, and also other bacteria initially may not present with gross sign symptoms. Zoonotic disease, especially the leptospirosis. Leptospirosis also common, not uncommon in our country. Relapsing fever and rickettsial fever. I have shown already the evidence of rickettsial fever, especially the scrub typhus, which is present with eschar, lymphadenopathy, and also the thrombocytopenia and rash, murine typhus, and rickettsial spotted fever. Also the parasitic disease, which is not uncommon, that is hepatic amoebiasis, and schistosomiasis and trypanosomiasis also not present in our country. So we can grossly divide acute febrile illness, localized infection, and no without any initial sign symptom. What is undifferentiated fever? If it is duration less than 2 weeks, if there's a lack of localizable or organ-specific symptomatic illness, and temperature is recorded more than 38 degrees centigrade. 5 major groups of causing acute febrile illness. One is the malaria, I already said, and different species of malaria, Plasmodium falciparum, which causes the severe form of malaria, arboviral infection, dengue, and other Japanese Zika yellow fever, which is not common, not present in our country, enteric fever, Salmonella typhi and paratyphi, spirochetal infection, especially the leptospirosis, tick-borne or louse-borne relapsing fever, and rickettsial diseases. So these are the 5 major groups of acute febrile illness of undifferentiated type. And if we see, there is a Plasmodium falciparum which is causing also a multi-system disorder, especially the Plasmodium falciparum, starting from the neurological manifestation. Even you can see there is a fundic changes, malaria retinopathy, especially this picture is given in the Davidson, and also in Kidom Medical College, there is a study on the fundoscopic finding of malarial retinopathy, like Roth spot finding and white extracts are found. And respiratory symptom, also there may be pulmonary edema and severe pneumonia, cardiovascular, heart failure, arrhythmia and shock, renal failure, acute renal failure, that is also called black water fever in sometimes. Abdomen, there may be hepatitis, jaundice-like features. Also in severe malaria, they may cause anemia, thrombocytopenia, bleeding disorder, including the DIC. On the other hand, leptospirosis, there may be bacterial or Wells disease or an icteric bacteria, leptospirosis, there may be an icteric form. They also causes GI symptom, pulmonary symptom, cutaneous manifestation in the form of rash, and the renal involvement, especially the proteinuria and RBC in the urine, which mimics with glomerulonephritis. Also, there may be jaundice, and which may mimics with viral hepatitis. And the closely their manifestation is related to dengue also. One study in ICGRB in 1999, they have found that those diagnosed dengue, they actually 19% was leptospirosis. They published in article. So this time already we know that dengue fever and its presentation in different presentations, severe dengue, probable dengue, and dengue with warning cell. I am not going details of the dengue fever because everybody know this time, and by repeated presentation by our today's chairperson, Professor Kazi Tariqul Islam sir. And a few words about the typhoid. We already know it. Very most commonest acute fever is the typhoid fever in our country. That is the first week manifestation, second week manifestation, rosacea spot. I will show the picture later on. And the diarrhea in the second week, constipation in the first week, and some respiratory symptom may be present. Also, there may be complication, though it is very rare nowadays because of very good antibiotic and very good response to the drugs. Even there may be rare complication like myocarditis, nephritis, and there may be carrier stage in the gallbladder where they can cause relapse of the fever. So rickettsial fever is a big group of fever, but in our country, epidemic typhus, murine typhus, and the scab typhus, and sometimes the Q fever are present. They have three basic presentation. One is the rash, eschar, and lymphadenopathy, which is classical presentation in scab typhus, but epidemic typhus and murine typhus, that did not have the eschar or lymphadenopathy. So this is gross presentation. There may be variable presentation of them, and there may be different vectors and organism of this rickettsial fever. And if we try to differentiate malaria, enteric fever, scab typhus, leptospirosis, and dengue, one is the important issue in rash, which is usually absent in case of malaria and also rare in case of enteric fever. But scab typhus, leptospirosis, dengue, we can see the rash. Eschar, that is the localized blackish ulcer-like lesion, which is common in scab typhus. It is the most important sign if we see it physical examination. Jaundice also common in case of malaria and rare or uncommon in enteric fever. Scab typhus in present, leptospirosis, jaundice is very common, and also dengue, hepatitis, there may be jaundice. Lymphadenopathy is not seen usually in malaria, but enteric fever is rarely seen, but scab typhus, leptospirosis, and dengue sometimes we can see in the lymphadenopathy. Muscle tenderness very peculiar to the leptospirosis, and muscle pain also present in case of dengue. That is why they liberate HGUT enzyme markedly than the HGPT in investigation it was found. And last aspirin, most of them the present in malaria, typhoid, scab typhus, and most of them. Encephalopathy can occur in malaria also, enteric fever, scab typhus, leptospirosis, and also in dengue. Acute renal failure is the most common presentation in case of leptospirosis, but also in second in malaria. In other type, there may be very rare or uncommon. Shock usually present in all the types, especially the dengue, leptospirosis, also in severe malaria. Bleeding more or less present, most common in dengue, but leptospirosis second, and also the enteric fever, internal hemorrhage can occur. If we look at the white blood cell finding in malaria, it may be severe, it may be leukocytes normal, enteric fever even normal in case of adult, but in case of children, there may be leukocytosis. Scab typhus, there may be low or normal in non-severe case, but high in severe cases. So more or less, they have same finding. Dengue has leukopenia along with thrombocytopenia, most characteristic early prediction of dengue if the NS1 is negative. So thrombocytopenia are present in all these group: severe malaria, severe typhoid, scab typhus, leptospirosis, and the dengue hemorrhagic fever. So in this way, there is some clue or sign how we can differentiate by physical examination and the investigation these 5 group of acute undifferentiated febrile illness. On the other hand, there are another group who says localizing clinical symptoms and signs, starting from the headache, vomiting, neck rigidity, suspected CNS infection, or unconsciousness when there may be encephalitis or there may be encephalopathy. Myalgia, arthralgia, and body ache in dengue, also in leptospirosis, photophobia in meningitis, encephalitis, conjunctivitis in leptospirosis, also in dengue, congestion, that is the congestion present, and skin rash is present in many situations, especially the exanthem lesion, febrile illness, lymphadenopathy we already mentioned, hepatomegaly in malaria, typhus, enteric fever, also in dengue, splenomegaly may present also in these conditions. Jaundice is common in case of viral hepatitis, also as well as in leptospirosis, severe malaria. And anemia may present in severe malaria as well as in case of leptospirosis. If we see, there are many manifestations in GI tract, in the liver abscess, hepatitis, cholangitis, in colitis, peritonitis, also the appendicular abscess and diverticulitis. Also, we can see severe many manifestations of cutaneous infection in impetigo, erysipelas, cellulitis, pyomyositis, osteomyelitis in case of bone. We also see neurologic infection, encephalitis, neurological abscess, cerebral abscess, and ophthalmitis and meningitis. So we can also see in upper respiratory tract and lower respiratory infection in the form of sinusitis, pharyngitis, tuberculosis, lung abscess, pneumonia, and emphysema. So in that particular case, we can see some localizing organ-specific symptom and sign. So we have to start examination from head to toe, and ENT examination is very important because sometimes it was found that there is a tonsillis enlarged, but person is not complaining sore throat or severe pain in the throat, and the cause of fever is the tonsillitis or sinusitis, even the acute otitis media or chronic suppurative otitis media, repeated infection, mastoid tenderness. So we can get signs, even the cardiovascular, the murmur in case of infective endocarditis, tender hepatomegaly, Murphy's sign in case of cholecystitis, urinary tract infection, suprapubic tenderness, narangal tenderness, pyelonephritis, even in case of gynecologic infection, we can see the discharge and the cervical motion tenderness, skeletal bony tenderness in case of osteomyelitis or monoarthritis. Even the dental infection can cause dental abscess, can cause fever, and the respiratory infection we can found the cracks, crackles, or bronchial breath sound, or even pleural effusion. Abdomen, we have maybe found the lump in different regions according to the cause of infection, also the organomegaly. The skin and soft tissue infection, I already mentioned different types of. and the lymph node enlargement, which may be regional or it may be generalized in different situations. So they are the potential diagnostic clue to find out the cause of acute febrile illness. So how we can approach? Our major approach is the history, and the history. 80% of your diagnosis can be made by history, which may be later on confirmed by the investigation. First, history, especially whether the patient is immunosuppressive due to diabetes, either malignancy or HIV or splenectomy or pregnancy, any history of bite, sexual exposure, occupational risks, especially the leptospirosis, animal contact, immunization history, drug history to exclude the drug fever, and travel history. Very, very important. Inside and outside the country, recent or past. If a patient visit a hill tracks and from Dhaka and the patient develop fever, we should think of malaria or we should exclude malaria first. If a patient come from South Africa with history of fever and other symptoms or weight loss, we should think of HIV infection. So it is very important travel history, and because nowadays many people are abroad from our country. And among the bites, it is most important the mosquito bite, which is related to malaria, dengue, chikungunya, filaria, and tularemia. And CC fly bite, it is not common in our country. Tick bite, which is common, it is a rickettsial infection, and also in Lyme disease. And the louse bite causes typhus, and flea bite causes plague, which is nowadays rare or uncommon. Sandfly bite causes leishmaniasis, and also redovid bug, Chagas disease in Africa. Animal contact, especially the cow and other goat, brucellosis, anthrax, and Q fever. Also the viral hemorrhagic fever in Congo, that is Ebola virus, and rabies, one of the important issue of dog bite, freshwater swimming, leptospirosis, Naegleria fowleri, meningitis, amoebic encephalitis, meningoencephalitis, exposure to soil, especially the deep fungal infection, and also the melioidosis, Barholderia pseudomeli infection, which is evident also in our country. Presentation may be lung abscess, by capillary lesion, cutaneous abscess, and multiple abscess in other parts of the body. Mimics like tuberculosis, raw undercooked fruit or vegetable infection, hepatitis, and also some parasitic disease, and maybe histolytica, echinococcus, undercooked pork, tinea sulium, neurocystosarcosis may be the presentation. Also, other unpasteurized dairy milk, it is the brucellosis, salmonellosis, non-typhoidal salmonellosis, abdominal tuberculosis, and untreated water may be due to enteric fever and other hepatitis manifestation. So this is important exposure to any sorts of bite, swimming, animal contact, exposure to soil, especially the farmers, and undercooked meat, fruit, or raw vegetables, etc. And also I mentioned that especially the farmer, the melioidosis, they can develop injection, tattooing, and body piercing. Transfusion also important cause of fever. So we have to any blood transfusion, any other sorts of transfusion. HIV, malaria, sexual contact, STD, syphilis, salpingitis in case of females, and also the HIV most important. I already mentioned the history of travel in African country and the Southeast Asia, almost same. All the infectious disease in India also our same, like infection, enteric fever, dengue, malaria, diarrheal diseases. Regarding fever, we have to take some important issue. What is the duration of fever? It is more than 14 days. It goes to the prolonged pyrexia, or sometimes we label it as a pyrexia of unknown origin when it is more than 3 weeks. Pattern remittent, intermittent, and continuous, and associated chill and rigor, especially some sorts of fever manifested with chill and rigor. But nowadays, due to effect of paracetamol and other antibiotics and early start of antibiotics, the chill and rigor may not be present in the fever, or it may not present at all. or whether the patient has any with or without localizing signs. One of the important issues is the documentation of fever. Most of the patient told us that he or she is feverish, but when we record temperature, there is no fever. So first of all, confirmation of documentation of fever is very important by the physician when it is more than 38 degrees centigrade and oral temperature recorded for 2 minutes. It is very important. Not the auxiliary temperature in a conscious or in except the children and the unconscious people. So it is very important documentation and maintaining temperature chart. Nowadays, it is not practiced in outdoor or hospital, not commonly practiced, but it is very important issue whether fever, what pattern of fever, and whether what is the characteristic of the fever to see the at least the recording every day is very important. And the rigor, I already mentioned, when there is chill and rigor, especially the UTI, malarial fever, abscess in anywhere in the body, hepatic amoebiasis, also cholangitis, they manifested with chill and rigor. It is some clue about the type of infection. Night sweat, especially important in case of tuberculosis and also in infective endocarditis. But there may be night sweat in non-febrile causes, especially the diabetes, acromegaly, lymphoma, as well as fever, also non-febrile stage, excessive environmental heat, anxiety neurosis, and alcoholism. Recurrent fever, sometimes whether fever occurring recurrent fever or undulant fever in case of Palestine fever, we have seen in Borrelia recurrentis or bacterial abscess, or even it is maybe seen in lymphoma. So accompanying history is also important. Starting, I already mentioned the symptom and sign of accompanying features of fever, which can guide us the localization of the fever. And delirium is more important in case of young children and the older people. Even the high temperature, they may go to delirium or unconsciousness. So if the patient, febrile patient is delirium, we should be very careful and hospitalization must. Myalgia, especially occur in dengue, influenza, even the meningococcal sepsis, and also shock may be in manifestation of severe infection and the sepsis. So all these features, characteristic, notable features, we should think of along with fever. And continued fever, already 3 types of fever, continued remitting, and continued fever never touches the baseline. There is a fluctuation more than 1.5 degree Fahrenheit, which is a fever is typhoid, miliary tuberculosis, lobar pneumonia, remittent fever. It is never exceeds 2 degrees centigrade, but it touches the baseline, amoebic liver cell lung abscess. But these sorts of characteristics nowadays abolished due to antipyretic effect. And intermittent fever, which only persists few hours in a day, which may be characteristic initially when in 3 types of fever, 3 categories. One is the quotidian, one is tertian, another is quartan, which is calm, quotidian, which is calm daily. It is the kalajor, double quotidian, it is called double peak, tertian, which is Plasmodium vivax, and quartan, 2 days interval, that is the Plasmodium malaria infection. But all this pattern may be absent or may not be visible. Other intermittent fever may be borreliosis, brucellosis, etc. Infection mononucleosis, also some sort of lymphoma, and also juvenile rheumatoid. And very important is the general examination of the patient. And temperature is recording, and I already mentioned which side of the temperature mentioned should axilla or oral temperature. Pulse is very important. Tachycardia is characteristic of fever. If 1 degree centigrade temperature raise, it causes 10 beats per minute. But there are some conditions where there may be dissociation between the pulse and temperature. Respiratory rate is increased. 1 degree centigrade temperature causes 4 breaths per minute increase. But sometimes pneumonia also increase the severe pneumonia, and pneumonia in the lung can cause the respiratory rate increase. So we have to remember simple temperature can raise the respiratory rate, but also the affected lung can causes the respiratory rate increase. Blood pressure may be low, even especially in dengue shock syndrome or early shock, we can see even in the severe sepsis or septic shock. Lymph node, which may be generalized or localized, we should carefully examine, and the characteristic features of the lymph node: consistency, regularity, fixation, mobility, so and so. Jaundice is also important to differentiate the viral hepatitis, cholangitis, liver abscess, leptospirosis, severe malaria, and all other viral hemorrhagic fever like dengue. Eye also important as a cause of conjunctivitis or systemic infection like measles, and fundoscopy very important in case of infective endocarditis, miliary tuberculosis, also in case of severe malaria, where you get some malaria retinopathy. Ear infection may be acute suppurative otitis media. We can see the tympanic membrane, mouth cavity also important for rash, especially the coblic spot, even the gum infection, tonsillitis, pharyngeal congestion, sore throat, etc. Skin may be meticulously examined to see there is any rash, ulceration, scar, swelling, or nodular lesion in the skin, even the bed sore, sometimes causing acute febrile illness in chronically ill patient. So these things, even the injection site, thrombophlebitis, sometimes we see in the hospital patient, there may be again comes fever or new arrival of fever due to thrombophlebitis. It is a common phenomenon in the hospital setting. Hands and nails should be examined, especially the infective endocarditis. There is a nail changes, and also there may be infection in case of scabies. Also in case of psoriasis, there may be nail changes. So generalization should not be ignored in case of acute febrile illness, and gives many clues to us to diagnose the fever for diagnosis. That is the fever and related bradycardia, many condition that is called facet signs, and brain abscess, legionella, especially the enteric fever, brucellosis, etc. In the Harrison, it is mentioned intracellular organism, gram-negative, tick-borne and other illness, viral illness. Dengue also causes bradycardia and myocarditis. Even the non-infection causes, drug fever, beta blocker use, concomitant, central nervous infection, malignant lymphoma, factitious fever, also one of the important signs to differentiate from the real fever, to see the temperature record and the disproportionate dissociation between the temperature and the pulse. It is also very important. So we should go for syndromic approach to diagnosis and treatment of fever, can help narrowing down the possibilities and simplifying the treatment. What is that? Common syndrome, we especially see fever with what other things are present, especially the rash and the arthralgia and arthritis, whether febrile and encephalopathy present, whether there is a multi-organ failure, whether fever with jaundice, fever with respiratory syndrome, fever with hemorrhagic manifestation, fever with neurological manifestation like neck rigidity, cardiac sign, or fever with GIT syndrome. So all these syndromic approach can help us to localize the lesion. Fever with headache, there may be simple high fever can cause also headache, but especially the meningitis, we should headache, vomiting, fever, encephalitis, sinusitis, even the typhus fever and pneumonia, and also other viral infection can cause. It is very non-specific, but sometimes along with fever, headache, if we get neck rigidity, then it is localizing sign. Fever, abdominal pain, vomiting, diarrhea, and malaise. It is one of the common is enteric fever, also hepatitis, even the amoebiasis and other viral gastroenteritis. Fever with jaundice, most common is viral hepatitis, dengue fever, leptospirosis, cholangitis, even the typhoid fever, enteric fever, hemolytic uremic syndrome. Fever with lymphadenopathy, I already mentioned, there may be many causes, bacteria, viral, parasitic causes, localized infection, and the generalized infection can cause fever. Among them is the rickettsial fever, brucellosis, leishmaniasis, chronic fever, even dengue. Sometimes there may be lymphadenopathy, very rarely infectious mononucleosis, tuberculosis, and the toxoplasmosis, anthrax, melioidosis. Hepatomegaly, tender and non-tender hepatomegaly, according to the cause of lesion, malarial leishmaniasis, and the amoebic or pyogenic liver abscess, typhoid, hepatitis, leptospirosis, even the disseminated tuberculosis. Splenomegaly is more or less common in same conditions. Jaundice, I already mentioned, and wheezing may be present in tropical pulmonary eosinophilia and low flood syndrome. So acute febrile with rash, it is very common. It is the measles, maculopapular rash, dengue and chikungunya. There is 3 types of rash in case of dengue. In febrile stage, we see the erythematous rash or maculopapular rash. In case of dengue hemorrhagic fever or critical stage, we see the purpura or petechial rash. In case of recovery phase, we see the confluent rash or white island in the Red Sea like fissures. Chikungunya, there is extensive maculopapular rash. Rubella has rash, scarlet fever, chickenpox, especially the vesicles and different forms of rash in the same patient. Meningococcal infection, purpura, malignant or big purpuric rash in case of meningococcal septicemia. And there is a day of arrival of rash. First day varicella, second day scarlet, third day pox. It is our undergraduate knowledge. 4th day measles, 5th day typhus, and 6th day dengue, and 7th day enteric fever. So these are the type of appearance of rash also sometimes may be helpful when the rash appeared in the body according to patient's history. And maculopapular rash, I already mentioned the scarlet fever, measles, rubella. In case of children, rubeola, typhus, typhoid fever, dengue, rickettsial fever, vesicular rash. In case of chickenpox, herpes simplex, petechial rash, meningococcal or other hemorrhagic fever, dengue hemorrhagic fever, infective enteritis, erythematous rash in case of cellulitis, erysipelas, pustular rash in case of staphylococcus or disseminated gonococcal infection. Especially sometimes rash on palm and sole is important. It is common in case of secondary syphilis, scabies, rickettsial fever, enteroviral infection. And nodular rash, nodular lesion even we can see in case of erythema nodosum, tuberculosis or leprosy and Behçet syndrome, even non-infectious vasculitis. So different categories of rash gives different clue of diagnosis. So we can see different types of maculopapular rash. It is also common in case of Zika, and there is a conjunctival congestion. These are the cutaneous anthrax, ASCAR, which is also common in our northern part of our country, and anthrax lesion. Time to time, there is an outbreak of anthrax. It is a centrally healed lesion, black ASCAR, surrounding inflammatory lesion and elevated margins. It is also seen in case of rickettsial fever. I will show it. These are the dengue in 2019, dengue incident. There may be vesicular rash in case of children, also some rashes and some arthropathy in case of chikungunya infection. These are the characteristic features of conjunctival hemorrhage with a icteric and the rash in case of leptospirosis. So very characteristic features with suspicion of leptospirosis. ASCAR, it is another type of lesion, is a black ASCAR, tick bite fever, scrub typhus, anthrax, tularemia, and spider bite, localized subcutaneous fever in case of Chagas disease, and nodular lesion already mentioned. And these are the characteristic features of leptospirosis, jaundice in a patient, conjunctival hemorrhage. This is one of my patients in seen the ASCAR in rickettsial fever. In our rickettsial study, we have found this type of ASCAR, and this is a big ASCAR, and this is a rash in case of typhus fever. These are the copric spot, maculopapular measles, and these are the rose spot, very rarely seen. It is actually not seen in our country, black skin color, but white people easily, it is very transient phenomenon in second week of disease. And these are the atypical lymphocyte in the blood film and infection mononucleosis, especially exposure to ampicillin or amoxicillin. They develop maculopapular rash. And these are the vesicle or herpes varicella zoster or chickenpox lesion, and variable stages of rash in case of chickenpox. That is the characteristic features. So I already mentioned, I am leaving this slide. Fever with arthalgia. Most common is the alpha virus. Most of the virus, among them is the chikungunya is common in our country, other is not available. Dengue is another, parvovirus infection, rubella, hepatitis C, EB virus, acute rheumatic fever, and septic arthritis. So we have to suspect when there is arthritis or arthalgia, these sorts of viral illness, and also the rheumatic fever and the septic arthritis. Fever rash with thrombocytopenia, with or without thrombocytopenia. This is most important. In dengue epidemic, thrombocytopenia not only present in dengue, but it is common in rickettsial fever, especially typhus, meningococcal infection, severe malaria, leptospirosis, and other viral illness. There might be less chance of thrombocytopenia, but still may present. But we have to remember the dengue, rickettsia, and the malaria, even the severe typhoid can cause the rash with thrombocytopenia. Bleeding manifestation patient may come, which is malaria, severe malaria, dengue, and also other viral hemorrhagic fever, Ebola virus, but it is not common in our country. And acute leukemia also can mimic febrile illness, and septicemia or DIC, kalajor, and leptospirosis. So these are the various forms of hemorrhage in case of dengue fever. And you see in the second picture, there is a conjunctival injection. Initially 2000, what is the dengue epidemic? At that time, NS1 was not available. We initially diagnosed the patient by seeing this sign, conjunctival injection. It is more than 90% of patient it was present. And another is the hand impression in the body. It is erythematous rash. It may also present in other viral illness. And this is the white island in Red Sea. That is the confluent rash. This is also sign of recovery phase in case of dengue. We are happy to see this sign and also the pruritus in recovery phase. Along with hemorrhage, there may be jaundice in leptospirosis. So these are the important issue. There may be multi-organ failure. It is mostly the sepsis or secondary to malaria, scrub typhus, and leptospirosis. Rickettsia, almost all the causes the same. These sorts of undifferentiated fever can present with multi-organ dysfunction. This is melioidosis. It is also detected in our country, and especially the diabetic patient. There is a many case report from the Badem, also politically different parts of the country, and also in abroad. Those as immigrant from Bangladesh, they have seen like tuberculosis mimics with tuberculosis, abscess, even the splenic abscess, in the lung abscess, also the cutaneous abscess, etc. So we have to think of melioidosis also. And acute febrile illness with encephalitis syndrome, especially if there is a negligible meningoencephalitis, also without sign, there may be due to encephalopathy, that is severe malaria, typhoid encephalopathy, though it is very rare nowadays, and scrub typhus. Fever with ARDS may be in scrub typhus, also in falciparum malaria, even the COVID, melioidosis, severe pneumonia, and also other tropical infection. Sometimes our surgical colleagues, they call us in the hospital for post-traumatic cases for pyrexia, acute febrile illness. Most of them are pneumonia at the third post-traumatic day, UTI due to catheterization in the third or fifth day, and IV catheter infection 5 to 8 day of post-operative, deep vein thrombosis post-operatively, sudden severe chest pain with fever and respiratory stress in pulmonary embolism anytime due to medication fever, also transfusion reaction. So we have to support our surgical colleagues for post-surgical febrile stage. These are the few causes of post-surgical state. How we go for investigation? There may be general investigation, there may be a special type of investigation, especially the culture and their specific investigation. In general investigation, we will go for complete blood count, peripheral blood film, liver function, kidney function, urine RE, and CS if needed, chest X-ray, ultrasound of the whole abdomen. In special cases, there may be CT scan of abdomen, chest, or brain may be needed, or CSF study may be needed. But in complete blood count, hematocrit is important. Nowadays in dengue, it is very, very important. Also, in severe malaria, there may be anemia. Also, rising hematocrit in severe dengue. Leukocytosis is also important in leptospirosis, which is called bacterial hepatitis, and enteric fever in case of children, but not in the adult, and also scrub typhus and hepatic amoebiasis. But all viral illness causes leukopenia commonly, and sometimes they are accompanied by thrombocytopenia, then rising titer of hematocrit. We label it as a severe dengue. Lymphocytosis is also present in case of rickettsia and viral illness. Most of the viral illness, thrombocytopenia I already mentioned. What are the causes of viral illness? Thrombocytopenia splenomegaly suggests malaria. Thrombocytopenia with bleeding manifests dengue, and also, but thrombocytopenia is unusual in simple malaria or uncomplicated malaria. Eosinophilia may be present in case of filariasis and Loflas syndrome. Peripheral blood film should be done all patients, especially in malaria patient, also filaria and borreliosis. So parasite count also correlate with the severity of malaria. Again, the fever with thrombocytopenia, these are important for our junior doctors. Dengue, severe malaria, severe typhoid, typhus fever, and the severe sepsis. And that we should not forget other causes of thrombocytopenia in this outbreak situation. Routine urine examination should be done. Sometimes in leptospirosis, proteinuria and hematuria may be found, and hemoglobinuria, that is the black water fever in malaria. And also we should go for liver function, kidney function. It may be affected by the especially leptospirosis, scrub typhus, and malaria. Bilirubin, especially the liver function, the CPK, and the HGUT, and the bilirubin, raised bilirubin, maybe CPK may be increased in case of leptospirosis. We differentiate it from the viral hepatitis, especially due to CPK. We can differentiate it from the dengue, also from the renal involvement. We can differentiate from the other causes. Renal failure is common in malaria, scrub typhus. So I am not going details. In the chest X-ray, we can see the pneumonia, organ-specific disease, also in secondary aspiration pneumonia or other involvement in case of melioidosis and also the leptospirosis. Ultrasound very helpful in case of dengue to detect the plasma leakage, ascites or effusion, and also helpful in lymphadenopathy detection, also in organomegaly, cholecystitis, and even the mass lesion in different parts of the abdomen. So organ-specific investigation, NS1 is the common. Already yesterday, Professor Kadir Toriko, our chairman sir, already mentioned what are the condition you may not get antigen, NS1 antigen positive, even the patient is suffering from dengue. So ICD dengue should be done after 5 days, and NS1 antigen should be done on the first day of fever. And any febrile patient, we go for exclusion of dengue first. But the confirmatory test, if NS1 is negative, we should go for PCR, but it is not commercially available, which is more confirmatory when there is absence of NS1 antigen. Malaria, we can easily diagnose RDT test and malaria parasite. Typhus fever, we can die by ICT, but it is very reliable. LIG is the most important, and PCR is the most confirmatory. Chikungunya also same thing. Sepsis is blood culture, and typhoid also ICT, but most sensitive, most specific test is the blood culture CS. And encephalopathy, you go for exclusion, CSF study, also the MRI, CT scan, whatever needed. And if you look at the sensitivity and specific test, confirmatory test, malaria test, antigen test is more than 95% and sensitivity and specificity, and microscopy is 100%. So these two tests is very easy for malaria. But in case of enteric fever, the antibody test ICT is very less, 40 to 98%, very variable. And also culture, it is 40 to 87%, but it is very specific. Vidal test, actually it is not valid nowadays, and we should not done the viral test for diagnosis of enteric fever. And also ascap-type, already I mentioned ICT, which is 66 sensitive and 92% specific. And also the welfare reaction, but all other tests are not available. We are doing the triple antigen test, which is not very specific and very sensitive. And also leptospirosis. Most important is the MAT agglutination test, but it is not available in our country, in our neighbor country, India, and it is available and it is common in their country, but in our country, in research purpose, we use the leptospirosis kit, and PCR is the most specific test. So dengue already said, the most sensitive test is the PCR. Now, some new hope for the new molecular method for identifying infectious disease. Tropical fever core nowadays available in our country. 7 organisms can be detected. Array system, Tagman array cut. We have done a study in BITD, also in Kidong Medical College. Film array technology we have done in Rohingya camp with the help of Foundation Mario in BITD, and also liquid beat array test, next generation sequencing. These are not available or not done here. Metric acid laser desorption or ionizing time flight mass spectroscopy. This test is written in the Davidson also. I like to show the first two tests. Tropical fever core test that identified told that the dengue, chikungunya, Zika, West Nile, Leptospira, Rickettsia, Plasmodium, and Salmonella. Tropical fever Asian variety, it is Japanese bee, and melioidosis also the spinaceous. But if there is an ongoing study by the ICDRB in different some special hospital in Bangladesh, I have seen a report few days back. There is acute febrile causative sensitive pathogen among hospital patients of selected hospital in Bangladesh. Ongoing study. You see the report, rapid test. All the dengue is positive, chikungunya is positive, malaria is positive. So it is very confusing, this rapid test. Sometimes we are in puzzle situation, which is the diagnosis. So actually the antibody test, they have less sensitivity and specificity. Just for example, I like to show, not for other purpose, for awareness of our participant audience. Tagman array cut, it is one of the important tests. I think in future, we will not face much more difficulty in diagnosis of these sorts of infectious disease. What we miss today, it is a combined test of virus, bacteria, protozoa, and fungus. It is designed. We got this Tagman array card from the Virginia University through Professor Ferdows Kadiri, help us to do the study in BITD, and it is done. One of my students, Dr. Tabassum, he done the MD thesis in tropical medicine, and this is published just in Clinical Journal of Clinical Laboratory Analysis just few days back. Tagman array cut in determining causative organism of acute febrile in hospital patient, and 120 patients they are studied, Dr. Tabassum Ferdowsi, and there is a shown in our study, Salmonella is the highest, second dengue, Pseudomonas, also Rickettsia, E. coli, and the histoplasma, fungal infection, Toxoplasma gondii, group Staphylococcus, Leptospira, 1% Coxiella, Staphylococcus aureus, cytomegalovirus, Brucella, 1 West Nile virus, Staphylococcus pneumoniae, Acinetobacter, and Klebsiella pneumoniae. So many organisms is detected by this Tagman array cut. And I think Dr. Tabassum Ferdowsi with us, if anybody want to know further query about the Tagman array cut, he will answer the questions. So it is very helpful, I think, but it is very costly, $50 per cut. We got it free. So in future, in near future, if we got these sorts of investigation, we can easily diagnose our acute undifferentiated fever into differentiated form. Another study done in BITD, film array, it is actually BioFire. This machine is supplied by Foundation Mario, who is support a lab in BSL-3 lab in BITD. They have made a lab about BSL-3 level. which is only BSL-3 level in Bangladesh. They studied in Rohingya children about the acute nasopharyngeal swab. And this is also another multiplex PCR test machine. And they have several panels. Respiratory panel we used, but they have blood culture panel, GI panel, meningitis encephalitis panel, pneumonia plus panel, and joint infection panel. Actually, it is used, US Navy, they use this machine for early detection and quick detection of the infection. And this is published in PLOS, Neglected Tropical Disease, few days back. Bacterial and viral etiology of acute respiratory infection among the forcibly displaced Mayana National in fragile setting in Coxbazar. Also, with collaboration of IDC, Foundation Mario, BITD, all this organization. And they have detected 5 bacteria, especially Astrococcus pneumoniae, Astrococcus aureus, influenza, and these 3, and also some virus, respiratory syncytial virus, influenza virus, ABC, and also human parainfluenza virus, also human meta-influenza virus. So different virus and bacteria detected from the, it is a case control study, and the viral load is seen less than 30, cyclical threshold, if less than 30, it is significant. So what are the red flag signs? We must admit the patient and give urgent treatment. This is very important for undifferentiated fever. One is the prostration. What do you mean by that? It is unable to stand, sit, or walk without support. Severe prostration is the most important point for hospitalization. If there is a hyperpyrexia or hyperthermia, if there is respiratory distress, if there is cyanosis or there is hypoxia, if there is a circulatory disturbance, hypotension is less than 100 systolic, or according to our chairman, sir, CCTBR, and the neurological altered mental state of the meningeal sign, abdominal pain that is common in case of dengue, or persistent vomiting, severe conjunctival palmar pallor indicating internal hemorrhage, jaundice, or petechial or purpuric rash, and bleeding from anywhere or the multiple site, which indicating DIC. So these are the situation where we should give admission to the patient in hospital and treat them urgently. So what treatment we can give in an undifferentiated fever, which is not still diagnosed? The empirical therapy is suggested. It is published in BMG journal that combination of parenteral third generation cephalosporin ceftriaxone along with doxycycline or azithromycin is appropriate while diagnostic confirmation is waiting. Ceftriaxone provides coverage for enteric fever and leptospirosis, while doxycycline coverage for rickettsial infection. So these 3 infections can be covered. Also the sepsis, UTI, pneumonia can be covered by ceftriaxone. So this combination is also appropriate for acute undifferentiated febrile illness, pneumonia and acute respiratory distress syndrome, even encephalopathy and liver involvement, and does not require dose modification in renal failure and multi-organ failure. So this empirical treatment we can start in case of if admission is needed, if there is a red flag sign or danger sign, so we give combined support or coverage of at least 3 to 4 organisms. These are the classical pictures we are using every day in our practice. That is septic shock, what combination, I am not going details, meningitis. It is written in the book nicely. So we can use these sorts of combination, different situation where our diagnosis is known. And one of the important issue is the febrile neutropenia, which is very dangerous, or neutropenic sepsis. In this situation, we should go for immediate treatment and very aggressive treatment, covering the anti-pseudomonal antibiotic, either piperacillin tazobactam, or cefepime, or ceftazidime, or meropenem, plus vancomycin if we suspect MRSA, plus metronidazole if we suspect abdominopelvic infection. And we should start antifungal if the fever is not subsided after 3 to 5 days. So it is very important in case of neutropenic febrile illness. And in soft tissue infection, which includes the Staphylococcus aureus and Staphylococcus either flucloxacillin, cephalosporin group, or clindamycin, oxacillin, we can use in case of skin and soft tissue infection, which may be the one of the important cause of acute febrile illness in the form of cellulitis, abscess, erysipelas, etc. So, Mr. Chairman, sir, fever presentation is variable from undifferentiated to localizing symptom, and many of them have common symptom of many of the disease we already seen. Meticulous history and examination is very important to reach a diagnosis. Syndromic approaches may be helpful for initial management of disease before confirmation the diagnosis. New molecular diagnostic method I have shown will be very helpful in near future for early diagnosis